And then next, our second session, our moderator is Dr. Wu Jingyi. She is also the president of Taiwan Association in Occupational Therapy Association in Taiwan. So let's please, Dr. Wu. Professor Wu. President Wu.
Hi. Sorry, I did not mute on my voice.
Okay, thank you.
Yeah. And now let's go into the second section. I'm Jingyi Wu, and I'm a professor of Department of Occupational Therapy at Chengdu University, and also the current president of Taiwan Occupational Therapy Association. I'm very honored and delighted to introduce our first speaker in the second session, Professor Director Tsuyashi Akiyama. Director Akiyama is Director of Department of Neuropsychiatry and Psychosomatic Medicine and President of Japanese Society for the Elimination of Barriers to Mental Health in Japan. Also, he will be President-elect of World Federation for Mental Health. Today, his topic is Recovery of World Capacity, World Federation of Mental Health Strategies for Anti-Stigma. Let's welcome Dr. Akiyama.
My name is Tsuyoshi Akiyama. I serve as president of the Japanese Society for the Elimination of Barriers to Mental Health, and also from this November, I'll serve as president-elect of the World Federation of Mental Health. Today, I make a presentation, Recovery of Work Capacity and World Federation of Mental Health Strategy for Anti-Stigma. I have no conflict of interest about this presentation. Work capacity provides a basis of social independence, opportunities to raise a family, and self-esteem. In this presentation, I will speak about the promotion of employment, rework program, and peer support activities. These three have been done in Japan, and I want to discuss a possibility for World Federation of Mental Health strategies. First, act on promotion of employment of persons with disabilities. This act in Japan obliges public and private corporations to hire a certain rate of the employees from disabled population. The last amendment was done in April 2018, and the content is the required rate of disabled employees were raised for private corporation from 2.0 to 2.2, for public corporation from 2.3 to 2.5%. And there's a penalty. If the corporation fails to hire one employee less than the goal, then the corporation has to pay 500 USD per month per person. So for a year, for one employee, short of goal, the corporation has to pay 6,000 USD. There's also a rewards, USD 270 for over the target rate employment. So this gives a serious incentive for corporations to try to meet the goal. Because of these acts, the employment of the disabled population has been gradually increasing, and especially for mental disability, the employment of for mental disability population has been increasing rapidly recently. The second theme is rework program. When a person has some individual vulnerability and exposed to some workplace stress, some develop mental illness. Onset of mental illness, unfortunately, usually the vulnerability is considered to increase after the onset. If a person with mental illness wants to return to work, then they will be exposed to the same stress. Vulnerability increased, the stress is the same. The logical consequence is relapse. So we need to provide some program to improve resilience to prevent relapse and so that the person can continue working. So we need a program to utilize illness management or recovery principles to prevent relapse at the workplace. Illness management and recovery program includes principles like a recovery strategy, illness information, and relapse prevention and stress management. Rework program in Japan utilizes these principles and provided in an occupational therapy framework. And participants do some occupational therapy tasks. However, the essence is psychoeducation and communication skill as an important part of stress management at the workplace. And also, participants need to reformulate their identity. Before the illness, the identity was, I'm all healthy, I have nothing to do with illness. However, after the onset of illness, the participants need to accept the fact that they now have to live and work with mental illness. So they have to monitor their condition and they need to use carefully their assets of work capacity. And the Japanese government subsidies this rework program. And this is prognosis after return to work. And obviously, the rework program participants showed a better prognosis after return to work for continuation work. In 1997, personally, I first developed this program, and as of 2019 September, there were 207 rework programs in Japan, and the estimated total capacity is around 4,000. So 4,000 people with mental illness receive rework programs so that they can return to work with controlled risk of relapse. The third theme is peer supporter training. Peer supporter, of course, can be voluntary or can be paid staff, and the Japanese government wants to include a system to pay for the peer supporter activities from this April. But in order to make the government pay, some qualification is necessary. So our research groups developed common and specific training courses for various disabilities. So training course basic is composed of 7 hours, 20 minutes courses over 2 days. The main contents are what is peer support, example of peer support, current welfare service, expertise of peer supporters, and this basic course is common to 5 core disabilities. 5 core disabilities are physical disability, mental disability, incurable disease, intellectual disability, and higher brain dysfunction. And after the basic course, each disability participant receive specific disorder-specific course. And the reimbursement started this last April, and so statistic is not yet available about the progress of peer supporters activities covered by this system, but hopefully at the next opportunity I can report to you. Now, as the last part of my presentation, I'd like to discuss the strategies. When something is considered to be useful, there's no stigma about it, and without any marketing, it will get accepted widely. We have had no stigma against smartphone. When we think of a strategy for anti-stigma, we need to take into consideration the concept of cost and effect. And if we can provide programs to assist recovery of work capacity, the effect is very visible. People with mental illness can work. And these courses do not require expensive machines. The cost is less. And if you understand the concept, again, the therapy is not highly complicated. So it is, these programs are easy to implement. But if society sees that our program help the people with mental illness can continue working, then they'll have a better image about the mental health, and then we can improve the opportunities for other anti-stigma activities. And when we do campaign, the campaign diagnosis, I guess, should be inclusive. Strategically, we may put more emphasis on moderate or common mental disorders, because it is easier for us to show effects or results. But again, when the society, general population has more positive images about common mental disorder, then it can be conveyed to the images for more serious disorder like schizophrenia. This is my summary. Work opportunity for disabled population can increase. And so I spoke about employment promotion, rework program, and peer support activities in Japan, but not only in Japan. recovery of work capacity is cost-effective and can be a good marketing strategy for anti-stigma. This is the end of my presentation, and thank you very much for your attentive listening.
Thanks, Dr. Akiyama, for his inspiring lecture and introduce us about the Active Rework Program, peer supporter activities, and WFMH strategies. We may have further discussion later on. Right now, I would like to introduce the second speaker, Professor Gabriel Ivbijaro, and Professor Ivbijaro is Secretary General of World Federation for Mental Health, also founder and chair of the World Dignity Project. Today, her topic is digital transformation and mental health, leaving no one behind. Let's welcome Professor Ivbijaro. Can display her speeches.
Thank you very much for giving me the opportunity to participate in this important symposium to be as part of World Mental Health Day 2021 celebrations and activities. My name is Professor Gabriel Ivbijaro. I'm the Secretary General for the World Federation for Mental Health. First of all, I want to start by thanking Mental Health Association in Taiwan for hosting and coordinating this event. And I want to give special thanks to the president of the WFMH, Daniel, for her leadership, the Asia Pacific Regional VP for being very helpful across the region, and of course, the conference organizers and each and every one of you. Without advocates, there's no mental health. So this year's World Mental Health Day is titled Mental Health in an Unequal World, Together We Can Make a Difference. What a title, what an opportunity for us to truly make a difference. And really, I want to thank all the contributors and volunteers who have made this possible. And I'm also very grateful to the technical team led by Mario and Steve for the excellent work they have done to ensure that we have our materials on time. So our president, Daniel, said very clearly that she wanted us to ensure we connect with the people, we connect with citizens and highlight the issues that face them. And we know inequality is one of the greatest issues facing our citizens. And according to the WHO, the orchestra, she highlighted the need of us to do things differently, especially as a result of COVID-19. And I think in 1995, the WHO said that one of the greatest problems plaguing the world was poverty and inequality. And I think it still remains the same. So we have to do something. We have to find a way to include everybody so no one is left behind. When the WFMH was set up in 1948, it began with some series of principles that all men were equal and that we needed to have a life course approach to how we care for things. They had the suggestion that the United Nations was important, the WHO was important, and education and science were very important. Why were they worried about this? They were worried at the time because of the crisis that was facing the world in 1948. And this led to a big meeting in London where clinicians, people with lived experience, lawyers, everybody were brought together and to set up the 1948 Congress in August in London at the Westminster Hall, Central Westminster Hall. And this was how WFMH was funded. Those issues in 1948 as in existence today, according to Professor Dr. Francis Hollande of France, he said, the President Hollande of France, he said that We are facing new challenges: wars, pandemic, inequality, stigma, natural disasters, inadequate access to medical and social capital, technological changes. Those issues were also the same that were there in 1948. They are the same issues now. And he suggested that we have to find a new mechanism for us to move things forward. We need to reinforce the role of civil society, local experts, and the population as a whole. It cannot be more right than what he said. We have to do something differently. We have to allow citizens to engage in their care, and we have to provide technology that will support them. See, when you look at technology and well-being, for example, for too long, we've focused too much on physical treatment and not health promotion. We focus on investment in hospitals, but not in citizens. So really, this paper that was written by Kate and their team actually says something to us, that we have to begin a new way, a new approach for health promotion. We need to invest in health and well-being. We need to prioritize treatment, but not as alone, but other things that makes it easier for people to have access to health. And I think, and I know that we have to begin to look at how we can use technology again. When you look at what has happened with the pandemic, that majority of the world was suddenly shut down and people were suddenly told to need to use IT. But for many people, many disabled population, IT, the infrastructure for IT were not there. And indeed, for people with mental conditions, about 70 to 80% of them do not have access to appropriate IT support. So really, how could we support their well-being when we do not provide the tools? So when you speak to physicians and you speak to patients, they tell you web-based interventions are here to stay. That is true. Mobile technologies are available. That is true. That access to health can be enhanced by IT. That is true. And you can integrate system with IT, which is also true. But as I said, but people who are disadvantaged have no access to IT. They cannot afford it. And they are not, some of them are not trained in the use of this technology. So how could we say IT technology is here to stay where we cannot support the people that really need it most? Yes, I agree that we can improve health with algorithm, but they will also provide their own challenges. So what are the ethical issues involved with IT? We need to look into that. We need to find a way to ensure that citizens are carried along. They are provided with the equipment and tools to ensure that the IT is not a hindrance to good care. So when I was thinking about this talk and also thinking about the chapter I wrote for World Mental Health Day, and I tried to look at why is IT important for mental health. So these slides, shows a pathway to care that I think highlights this point very, very clearly. Yes, the younger population have better access to IT, they are more confident with it, whereas the older adults may have difficulty or struggle. And also people with mental condition also do struggle. We do not have appropriate legal framework that enforces and enhances good care. And so we need to be thinking along that line. And really on the far right of this slide is what I'm talking about, that when you have good IT system, you have to have good communications. You have to have systems that will connect various systems. And so for it to happen, social care, housing, and going to be connected. And many of us, many of our patients, many of the people who live the experience do not have this enhanced opportunity. So one of the chapters in this year World Mental Health Day was written by UNICEF, and where they looked at children and young people. One of the key messages coming from that is that children and young people need good access to all sorts of care and support, including IT. So if you come from a poorer home, the disadvantaged population, you have less access to funding to support good IT support. So therefore, you are disadvantaged. And the Red Cross also says something very important, that we need to start worrying about crisis, how do we look at people in crisis situation? If you are in refugee camp, how can you have access to IT, good IT? So you can see already that the young people, even though may be competent, but as a result of poverty or social exclusion, they may not be able to have the appropriate IT that they need to allow them to have access to the care they want. If you are in crisis situation, you have the same issue hampering your access to care. So does it really matter? It does matter, because in the presentation in a write-up that I did with University of Bradford, we looked at the key changes that are happening to people with lived experience. And one of the things we found is that majority, up to 80% or more in some places, have no access to a good IT system or are not competent enough to use it. And when you also think about social care, housing, education, so we need to find a way to bring all together. So at the moment, most people are left behind. Our argument is that we shouldn't leave anybody behind. We need to think again about our digital transformation. We need to have clear pathways that will support digital inclusion. We need to ensure that people with lived experience have access to good IT system. We need to ensure that younger people have access to IT independent of poverty or richness. We need to ensure that people in crisis have good IT support so that they can harness the power and wellness of IT. So, and I'm beginning to think about rounding up that, in 2023 will be the 75th anniversary of the formation of WFMH. So really, we are hosting a Congress in London in 2022, and part of this will be for us also prepare for in 2023. We will be looking at all these issues again. We will have parallel sessions for IT, for care for younger people, care for older adults. So really, I hope that you will be able to join us. And I also would like your own experience. What is this like from your own perspective? Because we need to all learn together. So really, I know this is a whistle tour about how we can move things forward, but I'm very pleased to be part of this contribution. I would have loved to visit, to be part of to be with you physically. Unfortunately, as a result of COVID-19, that's not possible. But I look forward to visiting Taiwan again in the future. I have very fond memories of Taiwan when I was there, when I was president of WFMH. And I look forward to visiting you all again in the region. Once more, thank you for this opportunity, and I wish you success in this Congress. Thank you.
And thank Professor Ivbijaro, excellent lecture about the impacts of digital world on mental health and all of us. And digital world is coming and no one can avoid it. And we should capitalize on the advantage of technology such as web-based interventions, IT promoting engagement and adherence, IT tech promoting access and reduce cost. And we also need to emphasize the evidence-based medicine and combine the technology and EBN knowledge to apply in the individual and community. And thank for these two wonderful speakers. So these are two wonderful and worthwhile talks that help us to understand the efforts toward promoting dignity in people with mental dysfunction and having mental health in the digital world. Right now, we are going to the panel discussion. So for the first topic, the work issue. And I think the work capacity is very critical for everyone to function in the society and fulfill the necessary roles. So how we promote people with mental health dysfunction to work, which is very important topic. So Dr. Akiyama talked about the act in Japan and emphasizing the changes in the amendment about increasing the rate of employment in the companies, and which is a law for increasing the work. And also there are other strategies to improve the employment, including the rework program and peer support, which are well designed and implemented in Japan. And is there any other people or our audience who want to share the work experience in your country or your own experience? Dr. Susan Lee, would you like to share the experience, because you also take the project of rehabilitation, vocational rehabilitation for many years in Taiwan?
Okay, thank you, Professor Lee Wu. And this time I want to share some policy in Taiwan, because Professor Akiyama said something a penalty if not above the rate. In Taiwan, in public sector is 3%, and private sector is 1%. For the population rate and disability people. And the penalty, we have the one month for 800 USD dollars, more than $500. Okay, much expensive. And then our employment rate from 1994, only 4.9 in mental illness. And after 10 years, 2004, and raising to 9.4. And then after more 10 years, 2014 is almost 14.9%. So this time Taiwan is 15.3, and almost near Japan. They have the 15.9%. Yeah, and I think it's very near, very near. And this time we have so many programs in IMR, recovery, illness management, recovery management, and cognitive rehabilitation for dementia, for schizophrenia, for bipolar, and so on. Sometimes for intellectual disabilities. So this time we focus another people such as young onset dementia, because they have maybe younger than age under 65 years old. So they need economic issue. So we help them, young onset dementia, to keep in workplace or return to workplace. And we this time government emphasize on policy and regulation for us to do something for our people with disabilities. And this time, although pandemic, this time some economy not for us to do this, because we have to have some prevention for pandemic. So this time sometimes from leave from workplace, but in September or October, we do effort to raising their working in job working place. I think it's this time in Taiwan. Okay, thank you.
Thank
Maybe,
Dr. Liu's introduction. Yes.
Maybe Dr. Xu Shuting is on the line. She also do so much work rehabilitation program, work and accommodation. Dr. Xu, is you on the line or on maybe on YouTube, not connected here. Okay, and I also thank Dr. Xu and Hui Zi translate for us for Ingrid and Akiyama. Yeah, thank you. And Shu Ping and Professor Shu Ping. Yeah.
Yes.
Okay.
Yeah, I can share a bit experiences about what we did. So in Canada, there are lots of supportive employment programs for people with serious mental illness, and the employment rate is not bad. I don't have the number in mind, but people do get job after supportive employment program. However, recently I am conducting a research to see what's the critical ingredient for people with serious mental illness to maintain their job, to extend their job tenure. Because in average, after people get a job, their average length of work is no more than 1 year, usually a couple of months. So we want to see what's the critical ingredient to help people maintain their job. And so I think this is a very varied study, and we found support within and outside the workplace does matter. So people need support within the workplace and outside the workplace. And also they need to continually access the mental health system in order to maintain and support their job, as well as to improve their work-related resilience is also an important ingredient. So this is what we found, just a share.
And thank you, Professor Chen's sharing about the Canada situation. May I invite the Director Julie Wiener to share the experience in Australia? Or Jenny Miffer, can you share the experience or situation in Australia? Thank you.
Do you want me to speak? Is that who you were asking for?
Yeah, may I invite you to share the employment or work in people with mental health dysfunction in Australia, the employment situation.
It's what I would call very inadequate. The systems for support they exist, and on paper, in the policies, they're fantastic. But in practice, people tend to do what we call cherry pick. We pick the people who are most likely to make a roaring success of it very quickly. You know, people who've had an episode of anxiety or depression or first onset mental health issue. The people who have long-term mental health issues, who have capacity but are damaged by their care and treatment over the years, they have very little opportunity. But on paper, they appear to be employed because they're employed by workshops and supported employment programs where they do work, but for what they call pro rata wages. They are very, very poor level wages, and in many cases, I believe that they're being exploited. Instead of being trained to be work ready for the open employment, real employment, they're given jobs where they do routine, tedious tasks, where they're not developing broad-based skills. They're just being occupied. So it's a form of occupational therapy rather than what I would call real work. Peer workers who are properly trained, who work as specialised supporters in organisations and in the government departments, do real work for real wages and have real career options. People who are supported to go to university or do tertiary study, they get real work options, but it is not widespread. It's not, I would think, an effective way of getting and keeping work, because it's not just getting a job and staying there for 12 months. It's getting a job and being able to maintain that over a number of years, and to be supported to do that even when you feel inadequate and even when you feel that you're lesser than the other people around you. Someone who can just say, keep on keeping on. And I find it's not the mental health professionals that are good at this. It's the fellow workers and good managers who enable people to keep their jobs and succeed and progress through those career paths. It's almost never the mental health professionals, sadly, I must say, who pathologise a lot of the social ineptitudes. It's often the people in the workplace who are prepared to support and give the person a go. But I think employment is a massive issue. There's a lot of stuff going on in the name of employment that is really just occupational therapy. So that's my opinion. Thank you.
Thanks. Judy will share some your opinion.
Professor, I'm sorry, I probably missed the question while I just stepped outside. If you would just like to reiterate for me. I did hear what Janet had to say, and I have to say I agree. The old way of employing people was not equitable or equal. And peer workforce has absolutely had a growth in Australia, and there's more work to be done. What else would you like me to talk on?
Yes, we just want to you to share the situation of employment work for people with mental health in Australia.
Yes, so people have a diversity of roles, but there is an undertaking by health departments to ensure that people with lived experience are employed as peer workers in all inpatient units and in community health centres. It doesn't always work, and there's not always adequate supervision for people to maintain those roles, and there can often be a lot of isolation. But when people are adequately supported, and they can provide a vital role in education and advocacy and empowerment of individuals, and which is the primary goal of peer work, I would say. But it's not always successful, unfortunately.
Yeah.
But it is a growth market for us in Australia.
Yeah, thank you for your sharing. And the employment work are so important for everyone, especially for people with mental health dysfunction. And also, although there are a lot of challenge encountered for this issue, and I believe we, everyone or in each country will need to make efforts continuing to have the employment or rework become better and better. Thank you. And there are 7 minutes left. I would like to shift to the next topic about the technology, digital technology. During the pandemic, everyone is forced to use digital technology to communicate, to work, to have our life functioning. So at the same time, it's also very important for using the digital technology to improve or change our challenges to treat or train our patients or some people who need it. So the strategies or the way of using digital technology becoming an emerging issue to discuss or to think about it, how we can use it to in our clinic, in our clients. So is there anyone want to share some ideas about the use, the utilization, or the strategy of using digital technology in mental health? Is anyone to share it?
So, Professor, I was going to say that in Australia, because we've been in isolation and lockdown for quite a long time now, there has been an increase in levels of anxiety and depression evident in the Australian population. There's also been an increase in the use of helplines, telephone helplines, and in the use of apps and social media for people to connect with others, and warm lines. So warm lines being run by people with lived experience, supporting people, not as counselling services, but as to provide an opportunity for people to be heard and to express what's happening for them. So we've also seen in primary healthcare an increase in the use of telehealth facilities and video conferencing by doctors and psychiatrists and tribunals and all sorts of things too. Because of everyone being in lockdown, people aren't able to travel to appointments. So there has actually been a resurgence in the use of technology here in Australia. Thank you.
Yes, thank you. There is one question from Slido. Air crews in Taiwan, China have been in endless quarantine since the epidemic. Any suggestions for crews to adjust their mindset? Can I invite Professor Zhang Jue to have some suggestions for us?
I like to leave the chance to the other audience, like the friend from Indonesia. Would you like to talk about your country? Because we can open to all the audience. Yeah, I have many talk later.
Okay, so any speaker or any audience from Indonesia, would you like to share your experience or opinions about this issue? Thank you.
I would. This is Nancy Wallace. I would like to make a comment. It's been a very challenging year and a half for mental health services here in the United States, and I'm sure everywhere. We have been providing. I'm also a therapist, and I work both in a low-income clinic in New York City, where majority of my clients are on Medicaid and Medicare. And it's been a very challenging year and a half to continue to provide services. We have been doing telemental health services since March of 2020. And I also have a private practice, so I've had a chance to actually experience the difference between those people who have higher education and higher income and those people who are lower income and often live in poverty. And the difference is so significant in terms of knowledge about technology, the ability to use the telehealth services, access to equipment. Many of my clients in the beginning did not have access to computers. And so it was challenging to help them try to find ways by borrowing iPads and using their cell phones, which are not often adequate enough to have good communication through therapy sessions. And our system here has not took quite a while to get up and running to allow us to do the telemental health video system sessions with our clients. Very frustrating. It left a lot of our clients abandoned for periods of time. And there's such a disparity in the income levels with access and knowledge about computers that I think that telemental health services are really something that we need to really be promoting as a way to really providing greater access to mental health services to people who don't normally have it, like people who are in rural areas. But we need to find ways of providing proper equipment, and training, and to encourage this utilization of the telemental health services. I think it's a really important way for us to really increase the number of people that have access to mental health services. But I think it's going to require a great deal of resources and education, training, for us to get up and running with that. And it really needs to be targeted to people who don't have generally access to this kind of equipment or services.
Yeah.
Thank you.
Thanks, Nancy, Sherry. I think telehealth service is definitely important in the pandemic area and even after pandemic period. But I think it's an emerging issue that needs focus for discussion. And such as in Taiwan during the pandemic period, and there is almost no reimbursement for the telehealth services. However, some therapists, occupational therapists in hospital try to do some telehealth service. Like Nancy said, there are a lot of challenges there. No equipment, no proper equipment. No one can help a patient to operate the telesystem or how to set up the telehealth services. They try to do some activities such as help people to redesign their lifestyle at home by teleservice, or just a very simple system such as use line or use telephone. So that's just the first step, and then may help people with mental health dysfunction in the community to remind them to have medicine control or to go vaccine, and provide education about the COVID-19 prevention or personal health care. Okay, so I think it's a very interesting topic and needs further discussion in the future. Now it's 11:02 and we are running out of time of a panel discussion. So I think we just stop here, and we can go to the next activity.